hope you're having it's been a fascinating day, and I think it's going to be the highlight of the day for me, is with my friend Chris Klomp, who's Director of Medicare, Deputy Administrator of the Centers for Medicare and Medicaid Services. He's the poobah of all of this. And I just want to say, Chris, thank you so much for joining us. Thanks for joining us. Thanks for your patience as I ran to the little boys' room.
You know, I'm really grateful that we get to be here and we can have a conversation about bladder health.
Yeah, there we can. We
held it for 6
that.
hours and 42 minutes. That's impressive, but I don't know if it's healthy.
Yeah.
So that public service announcement you've done for all of us.
Well, thank you so much. And I've just learned a lot.
That's a bold statement.
I have anxiety about
my TMI. And
yeah, bold.
I'm proud of you.
So as you're, in this, and we were, we've had a number of talks around the healthcare ecosystem and how to improve it. And one of my beliefs, and I think you can have a lot of people on different sides of this, is that shaking up a system can often it shakes out inertia. It makes everybody go back to first principles and begin looking at what really matters in achieving health, paying for it, what kind of footprint. When we had John Brooks up here, we had a fascinating discussion about the decisions that you and he are making, in a way, are sculpting a healthcare order that you hope at the end of the day is far better than where we're at now. And so I'm interested as you're sort of looking and you're advising Secretary Kennedy and you're running all of the the systems you're running and looking at what you pay for and not. What are the biggest challenges for you right now in the moment on your radar screen of concern?
Look, these are not original. We have an affordability issue, despite the fact that we have the greatest healthcare system in the country. We know that. Is there anywhere in the world you'd rather be, is there anywhere else in the world you'd rather be to get care in that moment when you most need it than the United States? No, obviously not. But it's not available to everybody in the same way. And certainly from an affordability perspective, there are challenges. Mm-hmm. And I think the great mistake that's been made over decades of compounded policy decisions that were individually, I think, let's presume positive intent, well-intended, was that we treated healthcare, U.S. healthcare, like a market. Mm-hmm. And we assumed that market principles would fully govern. And yet there were critical aspects of that have been missing. And we know this, right? What's the economic definition of a market? There's a willing buyer and seller. Mm-hmm. Check, we've got that. The buyer knows what they're buying. Probably don't have that. I needed colorectal surgery a few years ago. Number one predictor of success of this particular surgery was surgeon skill. Mm. And so the result of which, if they got it wrong, was incontinence at a non-trivial rate. And so I wanted to know who was the best surgeon. Seems reasonable. Extraordinarily difficult to answer that question. So I didn't really know what I was buying. And then the third element of a well-functioning market or market at all is you know what you're buying. Price discovery, how much it costs. And we don't have that. And so first principles, to your point, this is why we're beating down the doors of transparency so hard right now. This is why we're so focused on this in our regulations and our rules and our rhetoric. Because an informed consumer is an empowered consumer. What does that mean to be empowered? It means you shop. Mm-hmm. I look at provider A, provider B, provider C. Some are high quality, some are low cost, some are low quality, some are high cost. And I choose the ones that are high quality and they're low cost. And what does that do to those who don't comply? They go out of business or they fix it. They become competitive on cost and competitive on quality. And then we go to them as well. That's basic. We see that in virtually every other segment of our economy except healthcare. So the system acts upon us, and it's frustrating as a patient because you feel like there's this inertial momentum working against you. It's hard. I have an immediate family member right now that's on a healthcare journey. It's deeply personal. It's complicated at the moment. I'm sitting there right with her. We're 4 weeks in on a prior authorization challenge. By the way, any close observer saw that one of the first priorities I was focused on with Secretary Kennedy and Dr. Oz last year was reforming prior authorization, and we are making really important strides in doing that. And I want to give credit to industry where credit is due, but I can tell you we're not there yet. Mm. It's difficult. It's difficult to navigate. Records got transferred from one facility to a specialist. They faxed them, by the way. It's 2026. Still using a fax machine. They faxed them to the wrong location. We don't even know where they got faxed. So somebody has my family member's records. That seems like a breach of privacy. That's a problem. So we haven't fixed that yet. Oh, and then by the way, the appointment got canceled the day before because we didn't get your records, so we can't meet with you. It took 2 months to get the appointment. Meanwhile, the health is deteriorating. So it just feels like there's this this pressure, and then you're getting these bills.
We had Brad
explanations of
Winstrip up
benefits.
here
It's not
talking
working.
about people that, were given instructions by doctors and covered, and then the insurance company wouldn't cover it. Like things like this falling out of the system there as well.
And this is for people who look, I run the largest health plan on the planet. And we're well educated. We have resources. I know the CEOs of the plan. I know the CEOs of the health systems. Like, it's very fast for me to fix this problem. And to my wife's credit, she asked me not to do that because she said it's not fair to everybody else and that we need to understand the problem and then I need to use it to actually fix it for everyone else.
Wow.
And I respect her for that tremendously. Like, that's the kind of person that she is, genuinely. So we're not there yet. We have to fix it. We need to restore market principles, first and foremost. And then we have to rattle all through. So prior authorization, that needs reform. It strikes at the point of greatest resistance in the patient's health journey, right? The peak uncertainty. I don't know what's going on. And then you tell me to wait and pause. We need interoperability. We can't have fax machines. We need digital interoperability. The record must belong to the patient. It's 2026. Every other stakeholder in healthcare is a steward, period, full stop. From the government to insurers to providers to vendors and everyone else. The record is yours. It's Steve Clemons, and it needs to go where you want it to go, securely and privately. You need to know where it goes. It should go where you need and want it, and that's it. Nothing else. We have to stop being held hostage as a country to that. So we're totally focused on that. And then we go after affordability. We got to actually pay attention to cost-adjusted outcomes.
Chris, you've been right in the middle of the tornado of a lot of the fraud remedy issues and fraud.
Yeah.
How big, from your gut, because I don't want to have overstatement or whatever, but I'm very interested in whether or not the system we have is just fundamentally broken. It has to be rebuilt. How big is the fraud system? Why isn't why aren't we using tools and whatnot to kind of create a prevention so that the system is stable enough that we're not talking about fraud and distractions from this, really focused on, making sure those people, who are in the CMS footprint, need Medicare, Medicaid, et cetera, are getting what they need and frankly deserve, as opposed to the distractions of a system that feels kind of warped.
Yeah, fraud, the cynical view, the cynical observer would suggest that the undertakings in fraud right now are a political exercise. Let me assure you, with all of the conviction I possess, that is not true. This is not political, it is not partisan, it is pervasive, it is a moral failure of the system, it is unacceptable, and there is a cost. And it's not just a cost to the taxpayer, Medicare and Medicaid, or to the consumer and commercial, there is a personal cost. Example, we went to LA County a couple of months ago. 18% of our hospice expenditures are out of LA County. I can tell you 18% of our beneficiaries and beneficiary deaths in Medicare are not in LA County. We went to a nail salon and a strip mall in Van Nuys where
so you
there
don't
were
need
40,
AI to show that to you.
40 hospices at the same location. We shut down something like 600 or 700 hospices in the last quarter. We heard from like 22 of them. Because guess what? When you're illicitly running a hospice and the government shuts you down, you don't write a letter and bring attention to it. So 22 of them complained. What happened to all the rest? The 578 or 678 or whatever the number was. So that's a problem. That's this $5.5 billion problem just in that geography, just in that category. And that's one category of dozens of categories where there's at least $100 billion just in the $1.1 trillion of Medicare. Then we've got Medicaid and we've got other programs as well. There's a personal cost as well. So a precursor to that stop in LA County, we went to Nevada. And we met with hospice providers and home health providers, and then we met with patients. And one woman came and she told a story about her sister from whom she was estranged, and she was on Medicare, and two women came to her door, and they didn't speak a lot of English, but they had a laminated poster, and they had pictures on the board, and it was like an oxygen machine and a wheelchair and a TV, and they pointed and said, you can sign up for this, it's free, it's covered by the government. And they enrolled her, unbeknownst to her, into an illicit hospice program. For those who are not careful observers of the Medicare program, when you join hospice, a physician is certifying that you are, to the best of their knowledge, terminal. You'll be dead within 6 months. And about 90% of the time, that's true. As a result of that, we provide more resources for you and your family in the process, but you no longer receive full benefits under Medicare. So if you actually have a problem and you need them, we're not there, providers aren't there for you. That's exactly what happened to this woman. She enrolled in a program she thought was going to provide care, and when she needed care, she didn't get it, and she died.
If you can make a strategic leap or make a big impact, and I'm not doing this because Lilly's sponsor, but if you can make a dent in the obesity status. We had Callie Means up here talking about what they're trying to do by way of foods and but if you can attack that from a lot of different directions, where you're actually not just creating a drug, but you're changing, you're creating, counseling, you're creating, new choices for people and kind of bringing the debt, a dent in that world. I think you were there that night when it was a Cafe Milano night where I was talking to Dr. Oz and also the then director of the FDA, and I just said, why aren't we able to count and use the money that would be saved from changing the vector on obesity in the country and somehow figuring out how to get credit? How do you score that in a way? And so that those expenditures that may be covered, under CMS and whatnot, might be seen as actually creating net positive economic benefits. And Dr. S says, absolutely. And it's even bigger, in fact, and positive than Lilly thinks. And so my understanding, and I may be wrong, in July, Medicare may be covering some of these GLP-1
That's right.
Drugs
$50 copay.
in a deal. So in that space, but I'm just interested in that. This is about bold bets, right? This is about changes. It's not just about getting any drug covered. The question is, are there strategic leap opportunities that could change the health profile of the nation in a major way? Maybe like that, but maybe other things that you see on your radar screen that I wouldn't.
Yeah, well, let's talk about obesity for a second. Obviously, 65% chronic disease rate, of which obesity is a part. 3 tiers of obesity that we think about: plus 40 BMI, 35, 30 below. All sorts of CKM, chronic metabolic disease, cardiometabolic disease that comes associated with that. In Medicare, we pay for GLP-1s right now if you have diabetes. Historically, we haven't paid for obesity. Right. Why not? Well, it's incredibly expensive. It wasn't clear what the math was. We didn't understand the adherence principles. We anticipated we could spend upwards of like an incremental $40 billion on them. We didn't know if it would actually make a difference. Obviously, as part of the president's most favored nation drug pricing policies, we announced, after negotiating with both Lilly and Novo, this $50 Medicare GLP-1 program to cover anti-obesity as an indication. How did we get to that point? We got to that point because the math actually pencils out in a really interesting way. One, we negotiated prices down on the diabetes side, which actually cross funds over to the obesity indication. So just from a pure taxpayer perspective, before we even start to think about an ROI and the net positive benefits, the deal looks really interesting on a 24-month basis. More importantly, 2 things start to happen. One, you get healthier, you feel better, and you're able to do your best work. You're able to be full potential. And our mission at CMS, I'm now wearing my CMS hat, separate from HHS, so you could argue HHS is the same mission, is to help every American unlock their full potential so that we as a country can unlock ours. Because it turns out if you're sick and you don't feel well, it's really hard to do that. And so we want to help people do exactly that. We want them to get out. We want them to accomplish their goals. If you're a grandmother and you want to hold your baby longer, we want you to do that. If you're a grandfather and you want to go hiking with your kids, we want you to be able to do that, not have your knees hurt, not be out of breath. And so that makes a ton of sense. And by the way, interesting data. I think obesity rate peaked 2 years ago at 39.9%. It's dropped 3% over the last 2 years. First time that we've seen that change in decades. That's a massive decline in 2 years. In no small part, I'm confident because of these therapeutics. So that's fantastic. We also believe then that you have corresponding offset reductions in cost because we don't have to manage that cardiometabolic disease that no longer manifests or that reverses as you drop. So this isn't a vanity project, it's a health project. That's the underwriting. That's why we did this negotiation where we landed in the price.
Are there other opportunities out there like that you see?
No question. And this is I think what you talked about with Callie. And it relates to obesity and extends beyond it, which is the most expensive care is the care that you don't need that you get. It's the care that we have right now. The care that we want the best of, the best care in the world, that's also the cheapest care, is the care that you never need in the first place. Why do we need so much care? We have 6.5 out of 10 Americans that have at least one disease, a chronic disease. 40% of them plus have polychronic. That's a problem. That's really expensive. It's expensive in their full potential. It's expensive from a cost perspective. And so what Callie's talking about, what Secretary Kennedy is doing, what the MAHA agenda about is answering the fundamental question of why. Why is it that the chronic disease rate has gone up what it has, and how do we change it? Why is it that we have 10,000 plus additives, dyes, and emulsifiers in our food supply? Why is it that the Medicaid mom of 2 who's shopping for food at the grocery store after working shift has to turn over the box of food and look and see what she's putting in her kids' bodies, even though a government agency that she trusts in, that the American people trust in, that starts with F for food, said it was safe? Why did we allow that to happen? Why are we allowing that to happen? And what do we do to change it? That's the root of what we're talking about in MAHA, fundamentally when it comes to food. You should feel safe knowing that what you put in your body is good for your body and it's not making you sick. We have the same questions about environmental factors, same questions about water. This is what Secretary Kennedy's espousing when we talk about MAHA. So that's core, and Callie's talked about it. Why is that such a big deal? Because it causes you to need less care. You save money. It changes the affordability index. It changes the supply-demand labor imbalance that we see right now, where we have far more demand for the care resources we have than we have supply. Most markets function, and this is a market principle that sits in healthcare. When that happens, the marginal price of the transaction goes up, and then it peaks, and then it prices people out. Except in healthcare, we can't allow that to happen because people need it. We are our brother's keeper. We have to render care. We need to render care. We need to help them be their best. And so those are the kinds of things we're focusing on. Why is it that this is the first time that this is the conversation that we're having as a country?
Right.
At this scale.
Can I get one more minute?
I'm grateful for it.
Because I think you probably have a heart out. Buddy Carter's here, but can I have one more minute? So the other thing I know about Chris Klomp is he's an incredible trade policy wonk. And I was so surprised, because you have your USTR background on this. But I mean, part of the health picture today is also knocking down trade walls, negotiating things, and and as you talked about MFN, but the MFN issue is complicated because you're dealing with the ecosystems for drugs and pharmaceuticals abroad, et cetera. Can you give us a very quick sketch of what you're doing on the trade front, which is also affecting the price picture for drugs in America?
MFN in its simplest construct was this: we pay 3 times what the rest of the wealthy world pays for the same branded pharmaceuticals. Those pharmaceuticals represent 9% of the scripts that we take each year, but about 85% of the $460 billion we spend on pharmaceuticals. So this is unfair. The president was bothered by this. He instructed us to fix it. It's a 2-part plan. Part 1, you've heard about. We've announced agreements with 17 major pharmaceutical companies representing 86% of the market, and we created a collective action of all of the major American and European, basically Western pharmaceutical companies. And then part 2 was to go to those countries and sit and say, if you want to continue to access Western manufactured drugs, and we want you to, then you have to pay your fair share. That's it. And so you saw that happen with the United Kingdom in 59 days. After 26 years of not doing it, they are materially increasing
and you helped
on branded pharmaceuticals.
Yeah.
It was a team effort.
Yeah.
We're doing the same thing now with multiple other countries. We're asking them to pay a fair share. We can GDP adjust it. We're not being unreasonable. We want them to pay a little more so that we pay a little bit less. They're not price caps. They don't stifle innovation. There is desire and support from industry, including here, for this to happen. And so it's a team effort. We're working on it together. At the same time, we're absolutely paying attention to American primacy in manufacturing vis-a-vis China, which is a major threat. And we do not want to cede that leadership position in the multi-trillion-dollar engine that it is to a potentially adversarial country that would then control what gets made and who gains access.
All right, I tell you, it's hard to meet someone who can pack more dense, fantastic information into a few sentences than Chris Klomp. I'm really, really grateful to Chris. He's a great friend, who's Chief Counselor of HHS, Director of Medicare, Deputy CMS Administrator. My friend, thank you so much for joining us.
Thanks for having me, Greg.